me works. I'll start again since the recording is in progress. Thank you. So thank you for coming to the webinar today from the AHRQ Academy. My name is Anne Roble. I am the project director of the AHRQ Academy, and I'm really happy to and excited to present this webinar today, From Bottlenecks to Breakthroughs, Innovations in Behavioral Health Integration. This is the first in our series, and so there'll be more webinars coming out through us. But we're really excited today to have Drs. Anna Ratzliff and Dr. Kari on to tell us some of their really important research and work that they've been doing in the last few years. So I'm going to just quickly, I know a lot of people are on here because they already know what integrated behavioral health is, and we want to get to our speakers, but I know there's a few new people and new faces, so we just want to give a quick overview here of what is integrated behavioral health, as well as what we do at the Academy. And so integrated behavioral health is a team of primary care physicians and behavioral health clinicians who work together to really improve the care of patients. And you can see on the left there, this is our lexicon from the AHRQ Academy. And you can see in the green, there's clinical functions, and then in the blue, you can see some organizational supports and community functions. And when all of these work together really well, we get really good integrated behavioral health care, and that results in improved patient care, lower costs, other improvements such as better health outcomes, lower mental health rates, and better care for them, as well as more effective healthcare utilization overall. Sorry, I'm waiting for my slides to catch up here. There's just a slight delay. Okay, so there we go. Why is integrated behavioral health challenging to implement? So integrated behavioral health care is great and it works really well, but there's a lot of reasons that it's challenging to implement, and that's sort of what our two speakers are going to talk about today, some of those reasons that we've found to overcome some of these barriers. So there's numerous barriers. I wrote numerous here and we limited it to 5 on the slide. There's a lot more as well, but often we hear people say that it's really tough for financing and payment models that aren't aligned to integrated behavioral health care. It's often easier to just refer a patient out versus actually building integrated care or doing it well. There's stigma associated with that, as well as workforce shortages. We hear a lot that there's a shortage of primary care providers, and so how are we going to train primary care providers who are also doing integrated behavioral health care when there's already just a shortage of primary care overall? And so within this space, we're all doing our best to improve and bring out integrated behavioral health care, but acknowledging that there's all these forces that make it challenging to do so. And so where do we come in? We're the Integration Academy. And we are sponsored by AHRQ, or funded by AHRQ. We provide a slew of resources and toolkits. This shows you our website at the bottom, which I know is how you all registered for this website or webinar. So I hope that you take a little bit of time or took a little bit of time to play around on our website if you haven't been there before. We have lots of toolkits, other resources, issue briefs on specific topics, tools and resources really for all levels of providers, patients, facilities trying to start integrated healthcare, or if they're already starting it, resources on specific things. And we provide a lot of that for behavioral integrated healthcare as well as MOUD. And we update this regularly. At least once a month, there's an update on our carousel, which is what you're seeing there, which means there's a new story or a new resource that we're highlighting. We do a lot of partnerships with other agencies and other organizations working in behavioral healthcare. And so we're always looking for new ideas. So if you go to our website and you think that there's a tool missing or a resource missing, we're happy to hear from you. Or if you just think do you have any tools about this? We're happy to hear from you. Or if you love something that we've done, we're also happy to hear things that are useful. So we really do hope you find some time to spend on our website. We also do these webinars like we're hosting today as a resource, as well as visit many conferences. So you'll see us around at some of those, presenting some of the resources that we provide. Check back, because we have a lot of exciting stuff coming up this summer, including other webinars, as well as some updated toolkits and really exciting issue briefs coming out. So we're going to transfer over to the webinar now. I'll provide a brief speaker introduction, and then our two speakers will give their presentations. Each will have about 30 minutes, and then we'll do an open question and answer forum. So please submit your questions through either the chat function box or the Q&A, and we'll work on our side to organize those and hold them for the end after both speakers have talked, but so that we can ask questions for both speakers. But please ask your question in the moment as you're thinking about it, and we'll keep a rolling list of those. The PI on the project, Garrett Moran, will also join me on that time to help filter those questions, so you'll hear his voice a little later as well. And then we'll wrap up, so that will take us through the webinar time. Sorry. There we go. There's a slight delay on the slides, but I'm really excited, as I said, to start this webinar series off with Dr. Anna Ratzliff and Dr. Kari Stevens. They've done a lot of work in integrated behavioral health. Dr. Ratzliff's going to talk to us about the NIH HEAL-funded CHAMP trial. And then Kari Stevens is going to talk to us about some digital tools in implementing that in the workforce. Their research is really exciting. I've gotten a sneak preview, but I'm really excited for you all to hear about the work that they've done. So I'm going to introduce each one a little bit before each section here. So when Dr. Ratzliff is done, then I'll introduce Dr. Kari Stevens a little bit more as well. So Dr. Ratzliff is a professor, psychiatrist, and national expert on collaborative care, and specifically on training teams to implement and deliver mental health treatment in primary care settings. And she's going to present to us today on the NIH HEAL-funded Collaborating to Heal Addiction and Mental Health in Primary Care, the CHAMP trial, addressing dual diagnosis, mental health disorders, and opioid use disorders in primary care. So I'll transfer it over to Dr. Ratzliff. Thank you for being here today.
All right, I think I'm good. You good? And I will just see if I can advance my slides. Okay, perfect. So really nice to be here. Thank you for the invitation. I am at the University of Washington, and I'm really excited to talk about these data because they're pretty hot off the presses. So we will go ahead, and before I jump into the details of the study, and I will talk about both the results as well as some of the implementation experiences of the teams that participated. I just want to make sure to acknowledge all of the people who supported this work. We had an MPI team that's listed here, as well as numerous groups involved in really driving the work that I'll be presenting, as well as acknowledging the funding from the National Institutes of Mental Health. So this study was really part of a large initiative called the HEAL Initiative. And so I just wanted to acknowledge that this was one of a number of studies that were funded during this period of time from basically 2019 to 2024 that were really focused on trying to both understand and manage pain and also improving the treatment for opioid misuse and addiction. Trying to make sure the slides advance. Okay, there it goes. Okay, so this was really the state of the world around opioid use disorders during the time that this project was initiated. And you can see on this slide that one of the big concerns that people had was that there were a lot of people dying every year from opioid overdoses. So the goal of this study was really to see what are effective strategies to engage people who are at risk for death from overdose, especially those who have an opioid use disorder. And there were a couple of big ideas that were incorporated into this trial. The first was that when we can actually get people onto medications for opioid use disorder, it really helps retain them in treatment. And that basically almost every day that someone is in treatment and not using, it lowers their risk for overdose. So that was a really important concept. And one of the goals of this study was to see how can we actually keep people more supported in staying engaged in medication for opioid use disorder, or MOUD. The other big concept was that this was really a trial looking at co-occurring disorders. So, one of the big ideas was that we know that collaborative care model, which is a model of integration, is effective for treating mental health disorders in primary care settings. So, I'm going to briefly review what the collaborative care model is. I know there's an audience here who many of you will probably know about these trials, but I want to make sure um, it's really clear what we were testing in our study before I present the results. So the model of collaborative care that we were really adapting was based off of the work of Dr. Jürgen Unitzer, and these were trials that were published in the early 2000s. The basic concept of collaborative care is that you're taking that relationship between the primary care provider and the patient and really adding in additional team members and a structured approach to mental health treatment in primary care settings, uh, basically utilizing the ideas in chronic care management. So in this case, you're adding in someone who's a behavioral health care manager. That person has two functions, both to help coordinate care of the entire team and also to be able to deliver brief behavioral interventions to that patient right there in primary care setting where they're already coming ideally and have an established relationship with the primary care provider, and a psychiatric consultant. And in this case, the psychiatric consultant often is not seeing patients in person, but is rather providing support and indirect consultation to the team through a process called the systematic caseload review, where they meet weekly with the care manager, talk about each patient, and help with both diagnosis and treatments, offering patients that whole range of treatments right there in primary care. So either brief behavioral interventions from the behavioral health care manager or medications prescribed by the primary care provider. So some of the tools and resources that the team really uses to provide these care include a registry to track the population of patients that have been identified as needing mental health treatment, active treatment with evidence-based approaches and that full range, both medications and brief behavioral interventions, and the regular use of measures to track response to treatment over time. So those are some of the core features of the collaborative care model that we were going to adapt for this study. Trying to move it forward. Not sure it's working. There we go. Oops, skipped over one. Okay, so I just wanted to say that the evidence base for the collaborative care model is well established with now over 100 randomized controlled trials showing that this works for various conditions, which I'll show in the next slide. It also has been shown that this model of care improves really across the quintuple aim. So improve access for population health outcomes, reduces total costs of care, has been associated with provider satisfaction, patient satisfaction, and has been shown to have equivalent or better outcomes across a wide range of different populations. The data showed on the slide was actually from that original impact trial and showed that at every site that implemented collaborative care, patients with depression in this case had better outcomes when using collaborative care compared to usual care. So this is a model that has robust evidence, but really hadn't been tested for co-occurring disorders, which is what we'll get into talking about in the next few slides. It has been shown, though, to be effective across a range of different conditions, including a couple of papers looking at substance use disorders. Okay, so what did we actually do in this trial? What we did as at the Ames, as the University of Washington, is we really wanted to test adaptation of the collaborative care team to address co-occurring disorders. So this is a slide that really describes the team and the functions in the intervention arm of the trial. So in this case, we adapted that role of the primary care provider to be able to prescribe both medications for mental health disorders, but also medications for OUD. Again, remembering that that's one of the most effective treatments we have to really save lives in opioid use disorder. We had the care managers trained up to be able to coordinate care for both those disorders, including behavioral activation for opioid use disorder that was adapted to really to help support those patients. And then the psychiatric consultant being able to support the team in the work of addressing both mental health disorders. In this case, it was anxiety, depression, and PTSD, as well as opioid use disorder. So we used all those same key principles that I've already described. And then the measures that were used in the study were whatever the appropriate mental health measure was, depending on the diagnosis, and a new 4-item opioid treatment response inventory that we really created for the study to be able to track response to the MOUD treatment. So this is the basic design of the study. It was a multi-site cluster randomized trial. We had pairs of clinics from the states that you see here on this figure. All of them were a matched pair of clinics in the same organization, and they were randomized to either provide collaborative care for both mental health disorders and OUD, or provide collaborative care for mental health disorders on its own, with the opioid use disorder being treated however they normally would have done it in the clinic before the trial. So in some cases that was referring out, in some cases that might still be a PCP prescribing that MOUD. All of the clinics had to be willing to have a provider that was willing to prescribe medications for opioid use disorder, had to have a behavioral health care manager and a psychiatric consultant. So really had to have those foundational pieces in place to deliver collaborative care. And we had 24 clinics that enrolled patients. Okay, so study aims. We had 3 major areas that we were interested in studying as part of this trial. The first was, does systematic screening for opioid use disorder help us identify more people with OUD? So that was a real question. We were curious if universal screening would make a difference in being able to recruit patients for this trial and also be able to offer patients access to treatment. Then the main question was, is collaborative care for OUD and mental health disorders more effective for patients with co-occurring disorders than if we were just delivering collaborative care for the mental health disorders only? So we'll talk a bit about those data as well. And then what kind of sustainment supports helps maintain this high quality collaborative care for co-occurring disorders, once the trial's over? So for AIM-1, these results are actually already published, and the answer to the question is that we did not find that systematic screening for OUD helped us identify more people with OUD. So this was a little bit of a surprising finding. Essentially, what we did is we had the clinics basically say, who's your population of patients, how many of them in the 6 months prior to initiating screening had a new diagnosis of OUD, and then we looked after the initiation of screening was put in place. Look at your population of patients, how many new diagnoses of opioid use disorder are there after we have routine screening in place. So what you can see on this is that there was, some of the clinics actually had a negative number, so fewer people were actually identified afterwards, and that the median pre-post increase was only 1.5 patients, so it was a really small number and not a meaningful number. So we really concluded that while all patients had the goal of implementing this, most also had some barriers around this. And that we really didn't see in this case that the use of regular screening had any impact, and probably not enough benefit to outweigh the costs, just in terms of time and effort that the clinics put into it, at least in the study sites that were included in this trial. we were really interested in learning a little bit more about why that might be. And so one of the things that we did is actually interviewed a lot of the clinics. So we had a formative evaluation throughout this entire trial. And these are some of the experiences of the people that were participating. I think everyone was a little surprised. I think when we first started, people were like, we're going to have 1 million people showing up that now have a new diagnosis of MOUD and of OUD, excuse me. And we didn't really find that. So I think that a lot of people really felt like they were surprised that you had to screen a lot of patients before you maybe found a patient that needed attention. And a lot of times they felt like, they were going to find undiagnosed OUD, but actually they generally knew in their practices who were the patients that had this diagnosis and maybe needed help. Okay. I'm sorry these slides are kind of slow and advancing. I'm trying to do it there. I can't. Okay, there we go. Oops, now I skipped too fast. Okay, so AIM-2 was focused on the question of, does the collaborative care team, if focusing on co-occurring disorders, actually more effective than if you focus on the patient's mental health disorder needs only. So for this, we recruited 254 patients. We had really good follow-up engagement with patients. So these were the survey completion. So we were really pleased with how we were able to retain patients over the 6 months of the trial. And our primary outcomes that we were looking at is the number of days of non-prescribed opioid use. Again, really saying even a couple of days might mean a big difference in people's survival, given the lethality of overdoses in opioid use disorder. And then we also were looking at mental health functioning. These are a few of the key demographics. These were a largely middle-aged group of patients. I think it's important to know, and I'll highlight, that most of the patients actually that ended up being included in the study were on medications for opioid use disorder at the beginning. We were surprised about this. We actually thought we would be initiating a lot of MOUD, so this was actually a slightly different patient population than we anticipated recruiting. But they all had mental health symptoms burden at the beginning of the trial, so we're eligible for that. So these are the results. These are new data. They're under review right now for publication, so you're getting a bit of a preview. But this is the main outcome. And you can see that there was a small difference, but it was statistically significant between the control and the intervention at both 3 and 6 months, showing that there was less use in the population that received the intervention. Again, that collaborative care that was really modified to address both their opioid use disorder and their mental health disorders. And even though these numbers are small, again, remembering that this is a very lethal disorder when not treated, these are clinically meaningful data, we believe, as well. I'm going to show just a couple other views of these results, just because I think there's some interesting data here to consider. You can look at that also as the number of patients with any use in the last 30-day window. And you can see that another way of looking at this is that our intervention lowered the total number of people that were using in the intervention group compared to the control. And you can also see that the number of patients with no opioid use at baseline who returned to use was actually also lower. So this seems to be really that the collaborative care intervention was really helpful in patients maintaining their engagement in their MOUD treatment. Okay, I'm trying to move forward again. If it goes, sorry, I'm trying to move the slide forward. Okay. All right, great. So this, however, we did not find a difference between the two groups in the mental health functioning of patients. So what we found is that both groups basically had pretty good, small, modest improvements in their mental health functioning. In some ways, I'm not super surprised in these results because we know that collaborative care, even collaborative care on its own, is effective for treating mental health disorders. Um, it was interesting to me that perhaps the addressing the OUD did not have as much impact on these results as we would have expected. So that's one of the reasons why science is important, is that you learn new things. In the last couple of slides for my presentation, I'll just talk a little bit about some of the experiences of the teams that were involved in delivering this care, some of the things that they found challenging, and some of the ways in which they addressed those barriers. So I think the first thing that's really important to note is that it was really challenging to keep these patients engaged in treatment. It was really hard to find patients, and then it was hard to keep them engaged to actually initiate treatment. We ended up under recruiting for this study, and I think part of it just was both fewer patients than we expected being taken care of in primary care, but also real challenges in actually, even if a patient was identified, getting them engaged in care. And that there was some sense that perhaps stigma, both in the community as well as in the clinic systems, might be contributing to some of these challenges. Um, Another thing that really came up was just the challenges around the structure of primary care. The study started in 2019, so you can understand that most of the trial was actually conducted during the pandemic. And primary care really struggled at times to be able to have the kind of access open that they hoped to have to be able to rapidly meet the needs of these patients. So, if somebody was identified on a Tuesday, it might be hard to find an appointment with that primary care provider in a timely enough way to actually get them started on treatment or really be able to address their treatment needs. And that some of that appointment scheduling processes were really thought to make it more challenging to actually get patients into treatment as quickly as people would have ideally wanted. Um, and that some of that was also driven just with the reality that in primary care, it's a very productivity driven environment, and the sort of longer appointment times or more complex care needs of these patients was in tension with the needs for clinics to be productive and seeing a lot of patients. Oh, we also found that some of the training that we provided was really, really important, and that people needed a lot of support around becoming comfortable, really both making a diagnosis of OUD, and also having those conversations with patients when that screening came up positive. And that patients were really complex, and that a lot of the people were saying that the mentoring and support that they got during the trial was really helpful in sort of, kind of getting over that barrier of being comfortable engaging in this work regularly as part of their primary care practice. And I think that even with that, there were some providers in some of the practices that were still concerned, or had hesitation about getting engaged in this work. I think people calling this sort of not necessarily resistance, but overwhelm, and sort of struggling with the idea of taking on another complex patient, I think could be helpful. Was one of the challenges, in that over 65% of the clinicians actually perceived that providing this care was really time consuming, and just, if you're a busy primary care provider, that can really feel like a major barrier in wanting to engage in this work. And that we also found lots of people who were really deeply committed to their patients and connected to their communities and wanting to offer these services in their clinic, and really focused on, we're just going to make it work, even though it is really challenging. So you saw sort of that whole range of attitudes when you looked at the clinic team members. So the third aim is what kind of sustainment makes high quality collaborative care for co-occurring disorders, helps maintain that. And due to our challenges with recruitment, we really didn't get to meaningfully engage in this aim during this trial, but we did towards the end of the study engage in assessing the teams that were involved, commitment to sustainment, and really what barriers they perceived or challenges they perceived, and provided some support around addressing those. So I think it was, even though all those challenges that I just described came up, I think people felt like when they did have a patient and were able to engage them, that was really meaningful work, and that they really wanted to maintain that capacity. And most of the time what that looked like is it was really that they had a collaborative care team that was addressing mental health disorders generally, and now could have that capacity to take on a patient with OUD when needed. So this wasn't that they built a whole separate capacity for these patients, but really broaden the scope of what their collaborative care team could really address in their primary care setting. And I think that that commitment to sustaining this was really driven by the comments that you see here, which is that the interventions provided were beneficial and life-saving, and that there was really a commitment to patient care in that way. Some of the things that clinics really identified as needs for sustainment included continuing to stay clear on their vision for why they were doing this work, continuing to maintain access to the collaborative care that could include opioid use disorder treatment. That there's a lot of questions on how to maintain clinical skills, especially because one of the things that we found is that there was a smaller number of patients than we really expected. In general, this was like between 1 and 5 patients on a person's caseload of collaborative care patients. And so maintaining all the skills and comfort in really addressing the needs of patients with OUD was challenging, because there just wasn't a lot of opportunity to iterate and work with patients consistently with those needs. And then, of course, and this was mentioned at the beginning, how do we pay for this care? Most of the clinic systems were either billing or were trying to work towards billing for their collaborative care team in general, and including these patients in that strategy. I'll just mention a couple of limitations. I mentioned this, but I think it's important to acknowledge that we really do have to consider these results in the context that most of the patients in both arms actually were already on MOUD. So it's interesting to think about. We don't know if these same results would be generalizable to patients that didn't start out on medications for opioid use disorder. And I think that's really some of the future directions that we see would be important in this work, is, do we see similar results with patients that are newly identified with opioid use disorder and might need that access to the medications? And I think I will stop there. I did include all the published paper references in our slide deck, so I think that the slides get put up later if you need that. But these are some of the publications that have already come out of this trial. And as I said, the main outcomes paper is currently under review. So I look forward to answering questions during the question and answer section. Can hand it over.
Thanks, Dr. Ratzliff. So we are going to hear from Kari Stevens next. That was fantastic. I should pause for a second and say that. And then I also want to remind people to throw their questions in the chat, because we will take those after Dr. Stevens's presentation, so we can sort of do a round robin style. So Dr. Kari A. Stevens is a practicing clinical psychologist in primary care, clinical research informaticist, and a vice chair of research at the University of Washington Department of Family Medicine. And she's going to share with us many challenges facing primary care for meeting the needs of mental and behavioral health, as well as how some digital apps and solutions can increase quality of care and address the human bottleneck. Thank you, Dr. Stevens.
Thank you, Dr. Rubel, and thank you, Dr. Ratzliff, for a great update on that big trial. I know I've gotten to hear interim results, so that was fun to get to see where you guys are winding up at the end of it. So thank you to the Academy for inviting me to come. I've got lots of things to share with you today. I'm also a practicing psychologist in an integrated behavioral health team within primary care, which I absolutely love doing Tuesday afternoons. So I get to be a clinician, but most of my time is spent being a researcher. And I'm going to see if I can try to master the delay in the slides that Dr. Ratzliff was talking about and figure out exactly how we hit this advance going forward. But if you hear me pausing, it might be because I'm waiting for slides to move forward. So here we go. So learning objectives today, I want to touch on a few different things, and I've got kind of a packed set of slides, but I've tried to scale back, which is hard for me to do. So I might go through a few things a little bit quickly, but as Dr. Ratzliff said, I think that we're expecting the slides to get shared out where I provide a lot of references to things if folks want to learn more. But by the end of this talk, I've got two sort of main goals for you all, which is first of all to have you all walk away being able to describe some of the challenges that we have in primary care to meet these complex mental and behavioral health needs, as well as how are we measuring in the level of integration within these practices? What are some advances we've been making recently related to that? And then I also want to help you all, oh, it actually advanced quickly. Oh, we're fixed now. Great. And then I also want to describe some recent innovations that we've been working on in several different study contexts that we've done that both talk about how we're advancing the level of integration in behavioral health in very practice-centric ways and what's going on with digital health solutions and how might that fit into the picture of integration. So as we jump ahead, I'm going to kind of breeze through a couple of background things because Dr. Rubel and Dr. Ratzliff have talked to you both have both talked to you all about some of these stark facts that we have. But you'll see on the left, this is a Center for Workforce Studies study that the center within our department has done here at University of Washington that really profiled nationally the behavioral health provider shortage. And I just think it's worth noting right here, you know, when you look at rural counties versus urban counties on the left there are huge shortages across all of our counties and particularly in rural counties. So it is just really paramount that we figure out how to do this integration better for the sake of all the suffering going on amongst very real people and communities. And I think all of us have either been hit ourselves or have loved ones, people within our circles that we know that have been hit with both medical and physical health chronic conditions that are pretty devastating for folks. On the right side, you'll see that the CDC is also showing just this steady increase, you know, and to Dr. Ratzliff's point with the pandemic coming in, it's disrupted lots and lots of services. And you'll see here the trend going up across all age ranges within patient populations with chronic conditions in general that are both medical and mental health related. So, you know, the problem is increasing essentially. We also know that the occupational burnout of our primary care workforce is quite high. So the study on the left is a study we published where we looked at almost 700 folks that account for every type of person that works in a primary care clinic within that sample across 42 clinics in over a dozen states in the United States. And the burnout's just really high. And you can see the different types of people that work within a primary care setting, and you can see the levels of burnout that we found. And this is just one little study that we did, but you know, this is repeated amongst many burnout studies. The good news side of it is on the right side, a study we didn't do, but one that was published a couple of years ago or in 2023, does show that if we do team-based care in a multitude of ways, not just necessarily the ones that Dr. Ratzliff and I are talking about today, but in all kinds of ways, just team effectiveness within these clinics actually help to really improve the provider's experience, lead to less burnout, and then potentially better retention of those providers where they intend to stay longer in those positions. So team-based care, really, really important. And we need to figure out how to do that in whatever shape or form is the takeaway. We did a study also nationally looking at what's the trend look like in terms of integrated behavioral health as one particular umbrella of how we do team-based care. So I'm going to jump into what are we doing kind of in this space around measuring this. A first stab that we've taken at this was a study that we did in partnership with the American Board of Family Physicians of a sample of over 25,000 boarded family medicine docs and asked them, do you work in a co-located way in some fashion with somebody who's doing behavioral health as a specialty? So it's exciting to see the blue coming forward on this map, where you can see that most states have some presence of that, but there's also huge geographic variation in that. Another thing you'll find in the study that I have below here as well is that that trend is increasing. And so we're at a point now where we were pretty close to half a couple of years ago of all clinics represented by folks getting boarded. And we had a 100% response rate because it was part of their boarding activity to fill out the survey, are now working co-located with some kind of behavioral health provider, which is really exciting to see that trend increasing. And it was working. I'm going to kind of in parallel look at our slides, so I can start at least speaking while we wait for the delay in the slides to come forward, see if that might help some. Okay, so the models of integrated behavioral health do differ potentially across. You heard Dr. Ratzliff talking about collaborative care, which is that third column of X's there. The column on the left, this is from a paper that we published a few years ago that I'll talk about in a couple of slides, which is a cross-model framework that we developed that sort of stretches across all these different models of integration. And you can see on the left different kinds of particular activities within practices that these models tend to address. I just want to make the point here that there are different forms of doing this in different ways, and so measuring this is really complicated. One of the things to know is that there are several different common ways to measure how integrated a practice is. There are 4 that kind of float to the top as being the most popular in terms of having been used, having been published, in terms of folks using this as a self-assessment tool that you can ask practices to fill out. So we've got the iPad at the very top, the PPAC, the MEHOF, and then AHRQ's integration playbook self-assessment checklist. These are 4 examples, but I will say kind of broadly across them without going into lots of detail on each one, that they tend to lack a behavioral anchor or really capture what practices actually do when they're doing integrated behavioral health. Some of these measures too are very particular to only certain models of integrated care, and none of these particular ones have been psychometrically validated. So one of the innovations that's come out in the last few years is the practice integration profile, or the PIP. And I bring this up because I'm going to show how we used it in a large national pragmatic trial. And so I want to get you guys familiar with this particular tool because it tended to address those weaknesses, or at least aimed to. And you can see on the right the different domains that it tries to capture and actually have behavioral anchors that help us understand what a practice is actually doing. And I want to give homage that the PIP really grew out of the lexicon for behavioral health and primary care integration that the Academy, AHRQ has helped support over the years. And it's a great resource to look at that really gives a deep, in-depth set of definitions and descriptions of what integrated behavioral health is all about. And then the PIP is really bringing that pragmatically forward as a measurement tool that also has been psychometrically validated to be able to really see what a site's self-assessment is of how integrated they are. The PIP itself does have these 5 different categories, and you can see a little bit here around what each of them tend to measure. Clinical services are asking things like, do you address certain types of diagnoses within the practice, and what kind of workspace you have. Practice workflow tends to look at different behavioral anchors around that flow between the behavioral health provider and the medical provider, and how well they're interacting and really joining together on the care. The patient engagement category is looking at what kind of strategies are being used within the practice to keep patients engaged in care and not lost to follow-up. And then integration and sharing methods are really about what kind of systems are you using together? Do you use the same electronic health record system? Are there communication strategies and shared treatment plans that are occurring across the team? And then case identification as well. What kind of screening are you doing? What patients have unmet needs? Do you have registries in place to track these things, et cetera? And what you can see on the right, and I've also cited Dr. Mullen's webinar. He has a recorded publicly available webinar at the link below that's actually really lovely overview where you can get more in-depth information about what I just talked about across all of these different measures and how the PIP fits in. And look and see that they're now evolving from PIP version 1.0, which is what we used in the study because PIP 2.0 didn't quite exist yet. But essentially, this is a quick description that they moved from the 6 domains, did some more psychometric validation. The PIP 1 was also psychometrically validated, refined it though into the 5 domains and really took the workspace domain, which was the 6th one from version 1, and pushed that into clinical services within the PIP 2 because they just tended to hang better together rather than be separate subcategories. So I think at this point, if anybody is interested in using this going forward, really the PIP 2.0 is the more robust resource. Another innovation that we've been working on to try to measure integrated care is to actually bring the lexicon forward to create some pragmatic definitions of what is integrated behavioral health in terms of what it looks like. We took a mixed methods approach with this and published this a few years ago, working with actually a lot of collaborators who also built the PIP and others to do a qualitative and quantitative joint methods approach to really talk to experts and practitioners and various community engaged folks that were working with us on this large pragmatic trial, and then nationally, folks that were working in all kinds of settings from the Department of Defense to federally qualified health centers, academic institutions, training, environments, et cetera. And also interview within focus groups. What do we define? What do we call this based on Donna Bedian's model of quality care, which really is about having processes and having structures that add together to really lead to the positive outcomes that we're shooting for. So what you see here is just a high-level summary of the 5 different groupings of processes. Each bullet represents a unique process that's important to understand if you're doing any kind of integrated behavioral health. These are processes that we would expect to have some kind of presence. Now, of course, every practice doesn't have each and every one of these, nor does it necessarily have all of the structures you see in that yellow column on the right, which are really about what kind of physical structures or financial, et cetera, structures are really in place to allow for this sort of work to happen. So we also did a crosswalk, and you can see all that in the paper I referenced below if you want to learn more about this, with the PIP itself, and looked and found that about 80% of the processes you see in these columns are represented and measured in that PIP version 1 and 2. And then about 44% of the structures were also included in the PIP. We took that cross-model framework and did a couple of things with it that I think were pretty cool to see. On the left side, we collaborated with ICSI on a Minnesota Health Collaborative that they were working on. And really, they formulated this model into their call to action where they were trying to define a gold standard across the state of Minnesota and all of the health systems that treat about 70% of the population of the state. And they were really clamoring for, what are they aiming at? What are they trying to create when it comes to advancing integrated behavioral health? And we were very humbled and excited that they thought that this cross-model framework that we were working on could potentially fit that bill, and sure enough, it did. So, I'm gonna call that a little bit of a real-world pilot test to see that this really did have salience for real community-based work that was going on just around quality improvement that was really key to help the populations of their communities. We also published another paper that looked at the MIHOF, a measure that I mentioned before, that got used within that statewide effort that measured over 100 clinics using that particular measure of integration and mapped that measure to the different processes and structures that are related to our cross-model framework. And what you're seeing on the right side is a graphical illustration of latent classes that we found across those clinics. Essentially, each line is a group of mutually exclusive primary care clinics out of those 105 clinics that show you how fully integrated they are across the dimensions you see on the bottom. And I know the text is really small, so really the takeaway here is we were trying to naturalistically see what are clinics tending to do around integrated behavioral health naturally. We know that we've published all of these wonderful models. We know that we have, really lovely definitions of them, but we don't know what actually then evolves in the real world. So it was really fun to be able to apply these two things to see there were sort of 4 groupings that tended to fall out, at least in the state of Minnesota as well. So one of the things we did for moving from ways in which we want to measure integration is really figure out how to meet practices where they're at. There is this giant umbrella of behavioral health that we're trying to impact when we treat folks in primary care. In primary care, we see everything. We see the whole person, and we see from birth to death, every possible problem that could hit a person physically presents somehow in primary care. So when you look underneath this behavioral health umbrella, there are many different dimensions in which we have evidence-based behavioral health interventions that could help all of these different areas. And practices are each sort of a family of their own. I'm in family medicine, so I really think in terms of community and family quite a bit. And we really need to address each of these groups with the respect they deserve to sort of meet them where they're at. So there's different ways in which we've spent time doing that. One way is to try to put up free materials, for example, and really adapt a lot of the evidence behavioral skills training into pragmatic snippets of free training. Here's examples on the left of 3 of those that I did in collaboration with the AIMS Center and other folks in Dr. Ratzliff's Department of Psychiatry and Behavioral Sciences at University of Washington, where I used to be faculty as well before I moved into family medicine. And on the right, Dr. Ratzliff and I worked with Dr. Nitzer and Dr. Caton to put a book together. And this was really meant for a primary care target audience to understand better how to treat specific kinds of disorders in a step-by-step fashion. These are sort of, ways in which we've done this for a long time. I think moving forward, we're really interested in trying to figure out how to give something to the practice on their own that's a bit more robust to help them target something specific and improve their integration in a way that they chose, in a way that they felt empowered and enabled to do. So we pitched a project to PCORI, the Patient-Centered Outcomes Research Institute, and got funded for an $18.5 million pragmatic trial to do this across the country. This was a 2-arm parallel superiority pragmatic cluster randomized trial, a mouthful, for a really large trial that really tried to work in the real world and say, here is a toolkit, essentially, a lean management-based toolkit that we want to test and see if we can actually improve integrated behavioral health within the clinics, and can we also improve patients with multiple of these chronic conditions that I just mentioned. And you can see on the right side the whole list of what these different chronic conditions were that we were targeting. And I'll talk a little bit in a future slide about what the requirements were to get into the study. But at the bottom, the reference here is the protocol paper, so you can learn more about the study there if you want to know more about exactly how we executed. The intervention itself, if I sort of describe this toolkit to you, these were really, again, based on lean principles that come through manufacturing for how you try and try again until you really get there and make a difference and find that right size solution. And this also took advantage of quality improvement methods, including PDSA cycles. So you see on the left, there really are these 4 components within the toolkit, 4 different stages, if you will, that we worked through. So these kind of come sequentially in time with each practice, where at first you really need to have leadership engagement within the clinic. We've really found over time through a lot of studies that if you don't have leadership engagement within clinics to make these kind of changes, you're sort of dead in the water. So you need to start there. And then plan a planning phase of really scoping and figuring out the boundaries of the workflow and the redesign that you want to do based on these lean principles. So the toolkit really gives these sort of methods for how you go about doing that. But each clinic is going to discover their own answers in that phase, and then redesign that workflow in a next stage of the toolkit with recommended tactics that we also provided. There were many of these tactics that they got to self-choose. None of them were prescribed as required. And then implement those changes again through these PDSA quality improvement cycles that most practices are somewhat familiar with. And I will say the practices loved this trial. We got very high enrollment for those that we approached. I think much because they knew that they could learn out of this toolkit lots of methods and strategies that they could reuse for other targeted activities, not just the one we were asking for. A second part of this intervention was the education module that we had. There were 70 of these asynchronous modules for every single member of the primary care team. So regardless of what your role was in the clinic, there were online materials for you to watch and look and learn about what is integrated behavioral health, because our belief really is that integration is done by the entire group of community-based folks within that clinic itself. It's not just done by kind of this person or that person, or it doesn't really fully kind of meet its fruition across the whole clinic. We also had interprofessional courses for all practice member roles. So anybody that was clinically practicing, some courses that targeted different practice members in different ways that were individualized. And the trainings range from 4 to 14 hours. The third and last component that we had of this intervention was really a coaching aspect where we had both a lead management expert and an integrated behavioral health expert and who was a psychologist work together with each of the clinics that were in the intervention arm for up to 2 years. So for anybody that wants access to the toolkit itself, it is published online, and that's what you see on the right if you want to be able to access it. So any clinic currently can now pull up this toolkit at will. There were 4 particular research questions that this study overall was trying to address. The first was does using this toolkit actually help adults with multiple chronic medical and behavioral health conditions? And does it increase the level of integration in the practices? Those were kind of the 2 primary questions of the study. We also wanted to look at what factors support and impede successful integration and then costs. And some of that's already been published in 3 and 4. A primary outcomes paper was also published that you see referenced below for 1 and 2. What I'm going to talk about today is hot off the press of a study I just published that actually looked at whether or not integration improved once we looked at the pragmatic nature of the way in which we implemented the toolkit. So that's what I'm excited to share with you today. But there have been several studies at this point that have come out of this trial. And we're waiting. Okay, so in terms of methods over this trial, we had 121 practices that were invited. We had 43 randomized practices in the end, 22 control, and 20 active practices with 1 that withdrew. And we had close to 20, let's see, 23, almost 3,000 patients as well. So you can see on the left, our inclusion criteria really included practices that had at least 1 primary care provider, a co-located behavioral health provider that was at half-time or more, a shared electronic health system, and they needed to be able to provide their EHR data for the study. And then on the patient side, we only were looking at adults who were seen more than twice in the last 2 years to make sure that they were actually engaged in care within the clinic. And to be eligible, they had to have either more than 1 chronic medical condition and a behavioral health condition, or 3 chronic medical conditions. So they didn't necessarily have to have a behavioral health or mental health condition as long as they had 3 or more medical conditions. I'm not going to go too in depth because there's a lot of slides here to keep working through, but you can certainly read more in the paper about all of the analytic methods. But essentially, we used a multi-level mixed effects model to look at both the intervention outcomes related to improvement in practice integration and whether or not we actually improved patient outcomes. And then we adjusted for a few different things that you see on the left and the right. So essentially, both of them were 3-level mixed model with these repeated measurements and then nested, as you see here in the slides. So let me not spend too much time getting into the weeds on that and just jump into where were we looking at patients from here and then get straight to the results, I think, which is the most exciting part. So there were 42 practices, as I mentioned, across 12 states. And this study was done, much like Dr. Ratzliff's, we did bridge over into the pandemic, although the majority of our study was done pre-pandemic, but a lot of our final outcomes, unfortunately, came after the pandemic hit as well. We also, to give you some description of who we included, we mostly had family medicine or mixed family and internal medicine practices throughout the study. The mean number of behavioral health providers at the site were about 1.5, and the mean number of primary care providers was about 6. And those are in FTEs, not physical human bodies, but the amount of full-time equivalent people working in the practice in those roles. In terms of patients, we had about half of them were married, about a third of them were disabled or unemployed, about 2/3 had a household income of $50,000 or less. A little over half had a high school education or less. And these demographics overall were generally pretty representative of the health system regions in which we had recruited from. And then the mean number of total chronic conditions that our patients had, most of them had over 4 in total. And over 80% of them had either had chronic pain, and over 80% of them also had hypertension. And then you see about half had depression, all close to half had diabetes, 40-ish% had arthritis, and then about a third had anxiety as well. Our practice outcomes, as I mentioned earlier, was the practice integration profile. The way that we used this particular measure was not to ask one person to rate that, but actually have 4 people at the practice do that, and then we averaged across without weighting any one opinion more than the other. And in particular, the 4 people we asked each of the practices to capture this measure with was a medical primary care provider, a behavioral health provider, an administrator. It was suggested to use a clinic manager or somebody equivalent or appropriate on that level, and then someone of their choice that they thought was somebody who would have a worthwhile opinion. And we let folks know that, oftentimes people respond to that questionnaire from their own lens. And so it's important to get these multiple perspectives to really get that measure best used. So results for those practice outcomes were very exciting for us as we did this nested modeling. And what we essentially found that you're seeing here is if you look at that vertical black bar at the 0, any lines that cross that is not a significant result, essentially. And what we were assuming and hoping to see in our hypotheses is that these numbers would shift to the right, which indicated improvement in integrated behavioral health at the clinic. At the very top row, what you see is the total PIP score. And then what you see below that for the PIP version 1.0 are the 6 different subcategories essentially that the PIP measures. And so, what you see are actually pretty big increases that we think are meaningful within the practice for not just increasing the PIP total overall, but across the majority of all of those subcategories that we were looking at. So it's pretty exciting because this was actually, pretty different kind of intervention that you see out there, much less prescriptive about exactly what practices need to do, but more empowering them to figure out themselves what they needed to do and seeing those changes occur. The patient outcomes we measured across 3 different scales. We used the PROMIS 29, which is a global set of actually several different function measures that are included, and you see those listed in the bullets there in that first box. But overall, we were looking at physical function, fatigue, sleep disturbance, social participation, your pain interference. As you could see, we had a lot of folks with chronic pain, and that's a very common plaguing issue within our primary care population, depression and anxiety. And then in addition, we sort of doubly measured, because the PROMIS 29 does include a depression and anxiety measure, the PHQ-9 and the GAD-7. And I'll just mention the PHQ-9, which measures depressive symptoms, is just very commonly used in practice for value-based contracting, for general delivery of care. So we thought it was important to be able to have that measure as well. And generalized anxiety disorder 7 scale is similarly pretty well deployed out in primary care. So jumping to the same way to read this graph for the patient outcomes, you're looking at that vertical black line, and anything that crosses over that vertical black line is showing you non-significant results. So in looking across all of these different measures of a patient population of close to about 3,000 and these 42 clinics, what you're seeing is that we really didn't find patient improvements per se. With them all crossing, essentially scores were not significantly different, except for a slight exception to that with anxiety. But I would say I don't think it's clinically meaningful. It was such a tiny difference that, I'm not sure that that's really worth interpreting necessarily. So I think that, our challenge that we had in looking at this is one of the pieces of data that I wish so much, of course, in retrospect, that we had was what level of service delivery did all these patients have. So it's possible that some part of this cohort never went back to the clinic during our observation period. In other words, because the design of the trial was an intent to treat design, and we wanted to really look at that cleanly across, we weren't able to account in these analyses, again, level of service utilization. So I think future studies really need to look at those patient outcomes more closely in relationship to just the pragmatic delivery of who's actually accessing these services. Okay, I will mention one last thing about this study, which is, and this is in the primary outcomes paper that Dr. Littenberg and company that we all published back in 2023, that higher integration, according to the PIP, was associated with higher levels of patient outcomes in the clinics at baseline. So this isn't necessarily associating anything with the intervention itself, but this is an interesting finding to see that association. Now, we can't say that's causal per se. There's lots of X factors that could potentially account for that, but I do think it's interesting to see, again, all of these that are not crossing that dotted line vertically are significantly either higher or lower if your PIP score tends to be higher. So again, correlation only, but we still need a lot more research work to understand how does integrated behavioral health overall in these various different forms it takes really relate to improved patient outcomes. So I promised as I turn for my last 13 minutes, it looks like, of this is to talk to you about digital behavioral apps. Where do digital therapeutics fit into this? How can they help when it comes to integration? So let me first start with, we've just completed a feasibility study. We presented last summer some of the results. We haven't published the final paper for this yet, but I can share with you the poster that we nationally presented of some of the preliminary results. This was a feasibility study we conducted with a non-FDA approved, so a brand new, hot off the press digital health app. We don't know how well it could perform or not, but it was worth trying to test out to see, is it feasible to actually ask patients in primary care who suffer with chronic pain to try out an app and see if an app that has intended to embed things like cognitive behavioral therapy and acceptance and commitment therapy into the way that a patient can daily interact with it actually improve pain interference over time. And so this was not a study that is an efficacy trial. It was not powered for that. So please, interpret it only as far as you can. But what we did see was a trend. And essentially, if you look in the box that I've highlighted here in our table, there's a little -2 number in there. Then again, I know the text is fairly small, but essentially what you're seeing are, we measured at baseline 1 month, 3 month, and 6 months after using the app. And you see a drop in the PROMIS score, and a difference of 2 or more tends to be clinically meaningful, a meaningful difference. And we did see a drop about a month after usage of the app, which also lines up with most apps are only used for about a month. And I want to say, I attended in our pain clinic for many years. I think I'm a pretty good pain psychologist, if I don't say so myself on some level, but I don't think I'm that good. I don't think I necessarily get my patients better in a month. So I think it's exciting to see that people might experience kind of a real difference and drop with just using a mobile app potentially. But again, we have to be very cautious in how we interpret these very preliminary results. So my team's been excited to look at digital therapeutics overall, and I want to spend the rest of the time talking to you about what's going on in that field right now. We're seeing a lot in the news. We're seeing a lot about AI. What does all this mean? Digital health apps. What do I mean by that? There's sort of 3 different boxes that I want us all to be thinking about. On the left-hand side, we'll kind of start with the highest vetted types of digital health apps out there in general. And those are what we call digital diagnostics and digital therapeutics. These are approved by the FDA. So those are technical terms. Digital diagnostics, digital therapeutics is a technical term that the FDA actually uses to approve and say, we have vetted this as being safe, and we have vetted this as having efficacy data of high quality. What they mean by digital is software as a device of some kind. And what's interesting is that more than 50% of these digital apps that the FDA has approved tend to be mental health related in some way. Others are also related to common behavioral issues like insomnia and chronic pain and things like that as well. So behavioral interventions are often now getting represented in what FDA is approving. A second category are health and wellness apps. And these are what I'm putting in yellow here. Use at your own risk, so to speak. So these are direct to consumer products. A lot of us have them on our phones, like the Calm app that I put on here as an example. A lot of us as providers do talk about some of these apps with our patients, even in clinical care, but these are not vetted per se. And they can change at any time because, these are all owned generally most of the time by for-profit companies. And they're not really supposed to be treatment necessarily, and therefore are not necessarily evidence-based. So we kind of need to be cautious about that to some degree, but it certainly has helped us extend tools in various ways like progressive relaxation or activity tracking and things like that. Then there's the third category, and this is probably what you hear the most about in the media, which are these entertainment apps, and a real question mark, I think, for all of us in healthcare, are they causing harm? Is TikTok being shut down, sold? Who knows? What's going on there? And chatbots, like Character AI, are getting sued from very scary stuff. And when I was looking at this talk, even just in the last month or so, and seeing what the latest was with the Character AI company itself, it's actually a lawsuit now because a child's died by suicide related to that company, and they're now being sued for an actual death. Whereas just a few months ago, when I looked at it, there were several lawsuits that were claiming harm to their children. So, these things are getting scary out there for sure and warrant a lot of attention. So I thought for this talk, I would include just a slide here on chatbots and throw out this question for us all. Are they good or are they bad? And just give you a couple of things that have been published here so that you can kind of keep up on what's going on. Because I think for all of us, this is moving faster than any of us can keep track of. The American Psychological Association has published an article that's up at the top left, and it's really talking about the use of generic AI chatbots for mental health support and the dangerous trend that's coming out of that. And so I think that's a great article to get you more clear on what the FTC, the Federal Trade Commission, is talking about in terms of risks there and what the APA says in terms of what they would recommend you talk to patients about, particularly parents of teens who are tending to increase more and more use of these types of things. Reuters also published that particular lawsuit that I just mentioned about this family who very, very sadly lost their son to suicide. On the right side, you can see a little bit of the summary of what's being said about these chatbots at a glance overall. So the FDA approving mental health chatbots has not happened at this point. There is no AI chatbot that has gotten through FDA. So let's just be really clear about that. These direct-to-consumer mental health chatbots are totally unregulated at this point. And they obviously might not be grounded in psychological science. You might have heard about Woebot or Therabot are examples of those. And then, direct-to-consumer entertainment chatbots are particularly dangerous because they're sort of extremely unregulated, claiming and feigning themselves as therapists. And again, particularly to kids or folks that are really suffering with mental illness who are looking for a connection, quickly, that are so freely available now. If you're having trouble finding digital therapeutics, you're not alone. So I've looked up a couple of resources to try to help us out to track on this. There is a group called the Digital Therapeutics Alliance. They're a nonprofit. They can't keep totally up to date, but I would say, I found them to be a fairly good resource to be a place to start to go see what they're touting. They do not have a comprehensive product library, but the apps that they do have seem to be well aligned with what FDA has approved. And so it's kind of a quick way to get a summary of some of the more hot ones, particularly from the companies that are putting out multiple of these apps. And then on the right side, the American Psychiatric Association has actually put together an initiative they call the App Advisor. And this is really just an educational tool. It's not a library of what these are, but it's a nice page that sort of helps educate people about what should you look for if you're trying to determine if a mental health app is actually good to use. So it's a great resource for clinicians, certainly, and potentially for the community as well. So in general, FDA approved digital therapeutics do a lot of things, and I thought, I've been looking at a lot of these. We currently are getting signaled by the NIH that we might be receiving a large grant to actually study how we can integrate these digital apps into integrated behavioral health settings. So I'm very excited to potentially get that project launched. And so as we've been looking and kind of scouring what are the apps that are out there, I kind of put together, this is sort of Kari's version of 6 bullets of what are the kinds of things we see these apps do. So at the top, you see a lot of them retrain things for us. They retrain our brain, sort of how we think, but even retrain some of the neurology and interaction that our neurons are having across the brain. They can help us do things to retrain our muscles and our nervous system. A lot of them also offer psychotherapy and biofeedback in various digital formats. And some of those are through apps. Some of them are using virtual reality technologies and wearables. Some of these are using integrated wearables to do things that I thought were pretty fun and creative, like interrupting PTSD-related nightmares before they escalate. So wearing an Apple Watch on your arm. This is not an Apple Watch, this is just my regular watch. But you can wear one on your wrist while you sleep at night, and it will sort of be able to read your biometrics to know that you might be likely experiencing a nightmare as you train that Apple Watch to know what that looks like for you at night. And then it will give a bit of a sensational burst to wake you up enough that you don't fully wake, but it interrupts that nightmare from progressing. Then there are others that do a lot of adjunctive support for psychiatric medications that people might be taking for various issues. So in other words, targeting populations that are taking medications and not necessarily responding as robustly as we would hope, and then being able to use these apps and actually seeing those results step up in improvement. Some are helping promote lifestyle changes, like being able to take medications more on a regular basis that are more closely adherent to what providers are prescribing, and also potentially doing more movement in their life. I don't want to necessarily call that straight up exercise. It can be all kinds of movement from small to large, and also doing various kinds of tracking of behaviors in general. And then there are also video games. For example, games out there that are helping people with ADHD, both for adults and kids, improve their lives living with ADHD, and of course more. So this is also a picture of what several of these look like. I just mentioned to you nightwear, which is in the purple at the bottom. That's that Apple Watch for potentially how you can get woken from nightmares. But there are several that you see here. Dr. Ratzliff just talked about, late-breaking research being done to help deliver MOUD for opiate use disorder. Reset O actually addresses trying to help people who are on various opioid replacement therapies, such as buprenorphine, be able to succeed better at being on those treatments for longer. You see various things for diabetes management, another chronic condition that affects lots and lots of people in the United States. Rejoin on the top left is one of those apps that's just emerging, that's helping link together two parts of our brain neurology, essentially, one that's short-term memory versus emotion recognition, and doing exercises on your phone to actually get those two parts of your brain lighting up together, which we know tend to separate and not interact when we're majorly depressed. And then others like WISA that help people reach an AI that helps them get resources better in these arenas. Oh, and then Endeavor on the bottom right, which are the video games I just mentioned. All right, so as I wrap up here, I want to just leave you all with, there's huge opportunity, I think, for these digital therapeutics because these lists are growing in terms of what the market is developing and what FDA now is starting to put forward that are worth our attention. Close to $7 billion is predicted just for this year to be invested in this kind of market. There are over 350,000 of these digital health apps at all those different levels that I talked about. But the vast majority of them have very few downloads in the world of apps, right? And then 3/4 of adults do turn to their digital devices for health-related information. And a few years ago, so it's probably higher now, about 2/3 of teens have used a health app of some kind. So our kids are definitely getting into this quite a bit as phones have proliferated amongst the youth at kind of all household income levels as well. But we still have a lot of reluctance of physicians to want to use these technologies, particularly around AI. And most of these apps do actually address mental and behavioral health conditions. So I think it's worth us paying a lot of attention to this and thinking about how we can get our workforce really ready to embrace this part of treatment potential. Then on the right side, I also thought it was worth mentioning, this was an article that recently came out in Nature, where they profiled over 800 of these digital health validation studies have been out there, but almost half of them had less than 100 enrollees. So this is very, very new science, and we really need to be looking a lot more at what are the barriers to dissemination in various ways and get much higher samples, testing more robustly. That said, there are two meta-analyses to be aware of that have come out recently in this last year. On the left, this was a compilation of 143 studies of digital mental health interventions that have been tested for depression and anxiety. And they found, by and large, the vast majority of those studies found high acceptability. So that's also exciting. Patients really do find these kinds of interventions acceptable to use. The meta-analysis on the right is 28 studies of the effects of digital therapeutics overall. And we do see that there's high potential coming out of this meta-analysis for the improvement in quality of life. It seems to be growing potentially exponentially. And there are very specific barriers and needs that have come out that I think, we've talked about that are very parallel with the same kind of barriers we have within integrated behavioral health. In addition to some new ones with these technologies that we really need to be thinking about what kind of science we need to innovate and reduce those barriers. The last couple points I'll make, I know I'm out of time here, is just looping us and circle back. So that integrated behavioral health cross-model framework that we had, where do digital therapeutics fit into that model? And I've taken the liberty to highlight in purple a bunch of these different bullet points across processes, as well as a bullet point across structures, to show you there's lots of places that we could see digital therapeutics potentially help improve the processes that we have for clinics that are working hard to maintain and improve their integrated behavioral health. So I think this is just, again, potentially, if you walk away from this talk with one thing, that there's a lot of exciting potential to have better reach, better access for all to the evidence-based treatments that we've developed over this many years. There's also a paper that I did not write, but is trying to actually look at how do we get health apps into clinical practice. So it was really neat to at least find a paper. I couldn't find any others, but there was one paper that sort of lists how would you go about doing that. So again, a place we really need to work. So I'll leave us with this final word of just saying, going forward, we have this giant umbrella of behavioral health that we're trying to address in primary care. We need to take practice-centric approaches to that. It's very possible, I think, to do that in lots of ways. And we need to really be embracing AI and tech solutions despite how scary they are. All right, so thank you again. It's been a real privilege to get to be here, and I look forward to helping with any questions folks have.
Thank you, Dr. Stevens, and thank you, Dr. Ratzliff. And thank you for ending on that positive note, because I was feeling a little scared as you were chatting, so I don't know how everyone else was. We have a couple of questions in the chat, and we also have a couple of questions that came in before the webinar. So I'll just raise those, but people can continue, participants can continue to put questions in the chat or in the Q&A box. I know it's almost 4:30 on the East Coast, so thank you all for joining us and hanging out. And if you can't hang out till the end of the Q&A, that's totally fine. Thank you for joining for the presentations. So 2 questions that came in through the chat were actually for Dr. Ratzliff, so I'll just start with those so I don't forget them. But the first one was about the clinics who were in your trial, and it was about their insurance makeup. And so I don't know if you wanted to talk a little bit about that, but particularly they asked about Medicaid population as well.
Yeah, it's a really important question because that often contributes to things like engagement and ability to regularly engage in care. So I put the link to our protocol paper in the question and answer section, and tell me if there's somewhere else I can put it. It is in the references, and that does include a really nice table that actually shows each of the clinics and what their payer mix was. However, like the big picture answer is it varied substantially. 3 of the systems were FQHCs. 6 of the systems were private not-for-profit, and those probably had a little more of a commercial payer mix or commercial representation in their payer mix. And then 1 was a publicly traded company, so they were all actually managed Medicare. So it was variable, and I think it's an important question. So those data are available if you want to go look at them in some more details. I guess I'll say I didn't see a huge difference in some of the things that we talked about, at least anecdotally, when I was supporting the practices and like which clinic system struggled more to get people involved. I think it was challenging in general to engage this patient population.
Thank you. And I'll ask the follow-up question there too, or I guess not a follow-up, but another question that was for you, which was in the Q&A, but I'll just read it out loud in case not everyone can see it. So one of the core features of the COCM model is that treatment is done in episodes of care, and with the goal that once goals are achieved, this episode is completed. So if we're treating patients with OUD and the goal is to maintain sobriety, abstinence, minimal use, does that change the model to being on one that doesn't include episodes but could be continuous?
Yeah, I think that's a really good question. I think for our particular patient population that was studied in the CHAMP model, care was continued for 6 months and then stopped. So, if the patient had completed their episode of care, and in general, because this was for co-occurring disorders, we were often treating getting people stay on a stable dose of MOUD, and then having patients have reductions or remission of their mental health symptoms as sort of the goals of the episode of care. I didn't go into detail. There's like so many things I wanted to talk about, but I was trying to be thoughtful about the time. So in this particular case, we really did conceptualize that as what we were defining the episode of care. I think that the sense is that especially if you can get people engaged early and get them supported and get their mental health symptoms addressed, we were hopeful that they would actually be able to then move to maybe more of a sustainment type model of their care, where they would probably be still being seen by that primary care provider in that primary care clinic to get their MOUD. So would still be getting treatment, but might not need the intensive services of the collaborative care team throughout, the rest of their life. So really conceptualizing that still as an episode of care. It's a great question, though. We don't have data on it. So, I mean, it would be maybe another future direction that would be really important, is understanding, are there other dimensions of how we define an episode of care that are important to have people maintain those gains that we saw in this trial?
Thank you for that answer.
Yeah.
That's really helpful to conceptualize it. I'm going to pause and ask Garrett, our PI on this project as well, if he has questions, because I'm going to guess he might have some for Dr. Stevens, because he's all about the therapeutics and things recently. But I'll let you ask whatever questions are brewing, Garrett, and then we can go back to a couple other questions that we got before the webinar.
Okay, thank you, Anna. And I see we are almost out of time, so I'll go very quickly. Dr. Stevens, I was curious what you thought about the recent report from the Peterson Health Technology Institute, which seemed to provide some very encouraging news about the potential of apps. Did you?
I'm not an expert on what that report says per se. So can you say a little bit more about some of the points?
Well, just briefly, it looked at 3 different categories: apps that are to support ongoing in-person therapy versus apps that are used independently, and then just sort of wellness apps, and generally had positive things to say about each of them, and positive returns on investment for the first 2 categories. So that was and actually, I think we need to talk offline, because I got a lot of topics I'd love to talk with you about. But
I would be happy to do that. I can say generally, so I'm sorry, I need to look closely at that and see what they say. I can tell you my own knowledge base about that is, I think that's right, that assessment of those, especially first 2 categories. I think we started out doing a lot of digital solutions to try to advance care that's actually happening, where we call it sort of having a human avatar, someone that you're seeing that's helping you do that. There was a great example of one at down in Southern California, a great psychologist who was working on campus with students and really frustrated that they were turning away all of these young people from care because they just didn't have capacity. Built a piece of software that said, let's give these students who are coming in for mental health care homework. And they went from seeing one patient for the 50-minute hour to 4. And they did 15-minute visits, and they were using the app outside of it and got really great results in 4 times capacity to reach folks. And that was years ago. So I think we also have seen over time, you need sort of that human avatar, but we're starting to figure out a little more of this independent piece of work. And I really do wonder if we can help push it out through primary care, where we touch most people. We could sort of have a proxy of that human avatar that doesn't have to be as heavy as that example I just gave you. So I think that's right. There's a lot of potential, but we really have to figure out the safety issues and how to vet, uniformly advise each other on what to recommend to patients.
Great, thank you, Annie. I'll let you.
I'll do one more question. I know we're hanging on, but I think it's sort of related to that. It was a question we got before the webinar that someone had submitted, but thinking about the implications of these devices for graduate medical education and training behavioral health professionals. So you touched on it a little bit, I think, in some of the papers, but I was sort of curious if you might want to highlight some of the opportunities there. Yeah,
that's a whole other arena that's exciting. So, I think that there's some establishment of some software solutions that, again, for-profit companies have been doing, one of which grew out of the University of Washington from a colleague of both Dr. Ratzliff and mine. that's really trying to promote a digital AI solution to looking at motivational interviewing training is kind of where they seeded and started a lot of work through R1 grants from the NIH that are pretty promising. And some of that technology now, and not just from that company, but across the board with LLMs now really moving forward in the AI world, large language models, LLMs, I should say. I think I said LM. Maybe I'm thinking about M&Ms with it being lunchtime. But anyway, large language models that are making this so much better and easier. That there have been some pilot pieces of work done, including some folks in my department trying to see if we can put together a tool to train family physicians how to get coached by an AI about how to talk to patients better, for example. So it would listen into that whole private session and then give direct feedback privately to the provider to say, you did really good with this part, but maybe not this part so much, or you could have followed up with that. So I do think those things are going to be emerging in education, and it's certainly aligned with ACGME requirements that we have within our family medicine residency program to have our behavioral scientists actually help assist training family physicians how to have that bedside manner, so to speak, with patients, for example. So lots of potential applications in education, I think, but I would say, I know we're out of time, but Dr. Ratzliff, you might have some ideas there because you do a lot more education than I do.
Yeah, I mean, I think there's a lot of interest, and could, instead of the AI be the therapist, could they be the patient, so that we can really practice being the therapist or the treating provider? And I think there's a lot of interest in that, and that maybe that is a really important strategy to think about training. In many other worlds, we do simulators before we do real life human kind of activities like flying and things like that. And maybe we should be doing that for behavioral health too. So lots of interest there. And we could probably have you could probably have a whole topic on training, which I think is actually really, really important. I mean, Dr. Stevens talked about that being a big part of her intervention in the study she designed. It became a huge factor in the trial that I was talking about. And I think it's a really important topic to be thinking about around integrated behavioral health.
Well, thank you, Dr. Ratzliff. Thank you again, Dr. Stevens. Both of these presentations were fantastic. I just moved to our final slide. Thank you, everyone, for attending as well. And we will post these on our website, the slide deck and the recording as well. So feel free to share it and reach out. Here's our QR codes if you want to, but you can also visit our website as well. So thank you so much, and I wish you all a happy rest of your Wednesday, wherever you are. Thank you.